Hello students, we will be discussing lung cancer staging and extra edge in respiratory medicine. So that could not be discussed in our regular classes. So lung cancer staging is very complex phenomena because you should have thorough knowledge regarding the anatomy of the lung, pathology of the lung tumor, radiology also. So it is a bit difficult, but let us go step by step to understand better for your exam. So we have for staging of any tumor something called as TNM classification. So T stands for tumor, N stands for node, and M for metastasis. And we are following the recent 8th edition of classification. Let us see the components. T stands for tumor. T stands for tumor. It will let me know the characteristics of a primary tumor. What is its size? What is its extent? Then we have N. N stands for lymph nodal involvement. Has the tumor involved any lymph nodes? Whereas M stands for presence of any metastasis. Presence of any metastasis. So by seeing this, what is the ultimate information that we get? Anatomic extent of tumor. So we will know the anatomic extent of tumor. So why this anatomic extent of tumor is important? For prognostic purpose. For prognostic purpose. By seeing the amount of spread of the tumor, you can roughly assess the prognosis. So if the tumor is less extensive, patient can have good prognosis. If the tumor is more extensive, patient will have bad prognosis. First we will start from tumor. Then we will go to nodal status. Then we will go to metastasis. Coming to the tumor status, we have something called as T0. So T0 means there will be no tumor. So T0 means there will be no tumor. Next we have something called as TIS. So this is the sequential order. So first is T0, no tumor. TIS means carcinoma in situ or tumor in situ. TIS. TIS means carcinoma in situ. Carcinoma in situ. So this is something new. So we can have either adenocarcinoma in situ or squamous cell carcinoma in situ. See, whatever tumor staging we are discussing now it is for non-small cell carcinoma, especially adenocarcinoma and squamous cell carcinoma, because these two varieties are very common and it can be asked in your exam. Whereas small cell carcinoma is further classified into an extensive, less extensive, that is generally not asked in your exam. So very important is lung cancer staging of non-small cell carcinoma. So which includes predominantly adenocarcinoma and squamous cell carcinoma. Then what is this adenocarcinoma in situ? So this you should have come across in your pathology. So it is an adenocarcinoma with pure lipidic pattern. So this term is also very important. It means there will be some abnormal dysplastic cells growing across the pre-existing alveolar septa. So it is not going to invade that area completely. It is going to only proliferate along the alveolar septa, and the size is generally of the tumor less than or equal to 3 centimeters. Whereas squamous cell carcinoma in situ is another variant. So there is also no penetration of the basement membrane, but has cytological features similar to those in frank carcinoma. So it is just something just before frank carcinoma going to happen. So TIS is carcinoma in situ. So either it can be adenocarcinoma in situ or squamous cell carcinoma in situ. So which will be known only after a sufficient biopsy. Then we have T1. So we have T1. So what is meant by T1? So tumor of size. So tumor of size less than or equal to 3 centimeter surrounded by visceral pleura. So it is surrounded by the lung covering. So lung inner covering called as visceral pleura. You can see. So the tumor is isolated less than or equal to 3 centimeter size, and it is within the lung covering visceral pleura. So surrounded by the visceral pleura, not involving main bronchus, not involving main bronchus. You can see in this image. So the size is important. So it will be less than or equal to 3 centimeters, and it is within the lung, and it is not involving any bronchus. It is not involving many bronchus. So further, based on this size, we have T1A, T1B, and T1C. So again in T1, we have T1A, T1B, and T1C. So T1A, the tumor size is less than 1 centimeter. So the tumor size is less than 1 centimeter. T1B, here the size will be 1, so 1 to 2 centimeter. So T1C, it will be more than 2 up to 3 centimeter. So T1A, it will not exceed 1 centimeter. It will be less than 1 centimeter. T1B, it will be 1 to 2 centimeter. So T1C, more than 2 centimeter up to 3 centimeter. So whatever it is in T1, it is not going to exceed more than 3 centimeter. So it is very localized. It is surrounded by visceral pleura, and it is not involving main bronchus. Now, if it extends further, we call it as T2 tumor. So it can grow in size, and it can also involve some other parts. So we have T2 tumor. So what are the features of T2 tumor? So we'll write it with another ink. T2 tumor. So first is the size. So when compared to previously, so this was the size, now you can see, so the size has increased. So tumor size more than 3 centimeter up to 5 centimeter. So it means it will not exceed generally more than 5 centimeter. It will not exceed generally more than 5 centimeter. Or the tumor is having any of these features, or the tumor that invades. So tumor that invades. So previously the tumor was Previously the tumor was within the lung, enclosed within the visceral pleura. Now you can see the tumor is invading the visceral pleura. So invading the visceral pleura, invading the visceral pleura, or the tumor can go and involve the main bronchus. So previously the tumor was away from the main bronchus. So now it is going and involving the main bronchus. So it is involving the main bronchus. So not as big as involving the carina. So it involves the main bronchus. And also it can occlude a bronchus and it can cause lung collapse or atelectasis up to the level of hilum, or it can cause atelectasis. So there can be a tumor involving a bronchus. So the bronchus is closed. So because of that, there can be a collapse and it can extend up to hilum. So atelectasis up to hilum. So T2, the tumor will be definitely more than 3 centimeter up to 5 centimeter. So this is the size. And the characteristics, it can either involve the visceral pleura, the main bronchus, or atelectasis up to hilum, atelectasis up to hilum. And again in T2, depending on the size, there is further classification. We have T2A, the size more than 3 centimeter up to 4 centimeter. T2B, more than 4 centimeter up to 5 centimeter. So it is very simple. T2, the size ranges from 3 to 5 centimeter. If it is 3 to 4 centimeter, it is T2A. If it is 4 to 5 centimeters, it is T2B. And generally it will be involving the visceral pleura, main bronchus, and it can cause atelectasis up to the level of hilum. Atelectasis up to the level of hilum. So here in this slide, we clearly discussed. So what is carcinoma in situ? So what is T1? So in T1, there is no invasion. It is enclosed within the visceral pleura. And in T2, the size more than 3 centimeter to 5 centimeter or involving the visceral pleura. You can see the a tumor involving the visceral pleura or involving the bronchus, or it can cause atelectasis up to the hilum. So here tumor more than 3 centimeter to 5 centimeter or tumor that involves visceral pleura, main bronchus, atelectasis up to hilum. Now coming to T3. Now either the size of the tumor increases or it invades more organs. So T3, so tumor size more than 5 centimeters up to 7 centimeters, or so this is a big tumor. So when compared to previously, these were small tumors. Now it is a big tumor, or tumor invading. So tumor invading chest wall or invades chest wall. So this tumor is large. So it is so large. See, these are the ribs. So it has invaded the chest wall. It has invaded the chest wall. Or the tumor can proceed into the pericardium. So this is the heart, okay, and this greenish layer is pericardium. So invades chest wall or pericardium or pericardium or pericardium, or within the same lobe, one or more. So one or more satellite nodules. So one or more satellite nodules. So one or more satellite nodules in same lobe. In same lobe. So see the important features. So either invades the chest wall apart from the size. So this tumor can invade chest wall. So tumor invading chest wall T3, or it can invade the pericardium. Along with a primary tumor, there can be one or more small nodules in the same lobe. One or more small satellite nodules in same lobe. And apart from this, in T3, we also have tumor which involves the phrenic nerve. So we have tumor that involves the phrenic nerve, and also a Pancoast tumor. So tumor of the lung apex. So Pancoast tumor involving nerve roots T1 and T2. So if it is involving only the nerve roots T1 and T2, so it is also included in T3. So T3, you should know this size. So it varies more than 5 centimeter. So the size is more than 5 centimeters up to 7 centimeters. So it will not be more than 7 centimeter, or tumor that invades chest wall. So pericardium, you can see the chest wall is getting involved here. The pericardium involvement, satellite nodules in the same lobe, or phrenic nerve, or a Pancoast tumor of lung apex that is involving, that can involve nerve roots T1 and T2. Now still the tumor has progressed. Now it is called as a T4 tumor. Now very simple, here size is more than previous T3. So size will be more than 7 centimeters. So it is a large tumor, or tumor that invades, or tumor invading. So tumor that invades carina. So previously only pericardium was involved. So now directly heart is involved. Then satellite nodules in another lobe. So in previously, suppose a tumor was found in upper lobe, we were seeing satellite nodules in the same lobe. So here, for suppose let this be the primary tumor, upper lobe, you can see satellite nodules in other lobe. So middle lobe, it means it has extended to various lobes in the same lung. It means it is disseminating more. And apart from that, involvement of diaphragm. So diaphragm and mediastinal structures such as esophagus, great vessels, recurrent laryngeal nerve, and also spine. So esophageal structures, mediastinal structures such as esophagus, great vessels, recurrent laryngeal nerve, spine. And with respect to Pancoast tumor, so Pancoast tumor involving nerve roots T1 and T2 was put under T3. So higher than that. Suppose this is a Pancoast tumor, so lung apex, so it can involve T1, T2. So if it extends further, it can involve C8. Still further, it can involve higher roots. So Pancoast tumor that involves C8 or higher nerve roots. So C8 or higher nerve roots. So this is with respect to T4. So size will be more than 7 centimeter. and it will be more aggressive. So directly involving the heart. You can see here it is involving the heart, involves the diaphragm, goes and involves the carina. So there can be satellite nodules in another lobe. Apart from that, esophagus. So there can be involvement of esophagus. There can be involvement of great vessels, recurrent laryngeal nerve. So spine is also involved in T4, and Pankos tumor that involves nerve roots C8 or higher nerve roots. So this is the important classification. What you should know is, so T1, the size you should know. So 3 centimeter. So T2, 3 to 5 centimeter. T3, 5 to 7 centimeter. So anything more than that is generally T4. And also the pattern of invasion. So pericardium is T3, directly the heart is T4. Esophagus, great vessels, recurrent laryngeal nerve, spine, everything comes under T4. So this completes the tumor status. So the size and the amount of extension, we have T1, T2, T3, T4. So you can once again have a look. So this is the important T1. So we have seen T1, T2. And next we have T3, T4. Now coming to the nodal involvement. So nodal involvement. So node staging. So this is also very important. First, let us see the basic anatomical stages. So to understand this better, you should know the normal mediastinal structures, and also you should know some amount of lung anatomy. If you see in this image, so this is the central airway called as trachea, giving rise to bronchi within the lungs, and within the mediastinum we have esophagus. So esophagus will be posterior to the trachea, and from the heart there will be arch of aorta which runs in this way, and ultimately it goes posterior to the left main bronchus, so then it turns anterior. So this is the basic anatomy that you should know for understanding the various lymph nodes. So let us see the various stations of lymph nodes. So the stations of lymph nodes, we have supraclavicular. So first important station is supraclavicular. So consider, so this is a clavicle. So let this be the clavicle. So let this be the clavicle. So any node above the clavicle, these are considered as supraclavicular nodes. So first important station, so the important group is supraclavicular. So and it is generally first station. Then next important group we have superior mediastinal. Superior mediastinal. We have superior mediastinal. These numbers 1, 2, 3, 4 are some standard numbers that we give to the lymph nodes based on the area they are involved. So first category we have seen supraclavicular. Next category that we have is superior mediastinal. So within the superior mediastinal we have upper paratracheal. So so these are supraclavicular, for example. So now let us see upper paratracheal, upper paratracheal. So this may be like this. So upper paratracheal. So in the upper portion of the trachea, around the trachea they can exist. So then prevascular or retrotracheal. So prevascular generally before the trachea. So retrotracheal generally behind the trachea. So there will be group of lymph nodes. So before the trachea, behind the trachea. So it can also be involved. So this can be involved. So when it is involved, so we have to say, so the number 3 category of lymph nodes have been involved. So then we have lower paratracheal. So around the trachea in the lower portion. So superior mediastinal, we have upper paratracheal, prevascular, retrotracheal. and also lower paratracheal. Coming to the next important group of lymph nodes, see the aortic lymph nodes. So aortic lymph nodes, we have subaortic. So somewhere here subaortic, and also around the aorta para-aortic. So subaortic, para-aortic, subaortic, para-aortic. The next category, inferior mediastinal. So inferior mediastinal. So subcarinal. So this is the carina. So bifurcation is the carina. So there can be subcarinal lymph nodes. So paraesophageal lymph nodes. So paraesophageal. So this is the esophagus. Around the esophagus we have paraesophageal lymph nodes. Then pulmonary ligaments will be nearer to the mediastinal pleura. So nearer to the mediastinal pleura, there will be pulmonary ligament. So that is a residual structure from the anatomical development. It is seen near the mediastinal pleura. So very simple. We had supraclavicular. So I will just show you here. So supraclavicular. So this is the supraclavicular. So then we had superior mediastinal, in that upper paratracheal. So prevascular or retrotracheal. So just change this. So this prevascular or retrotracheal will have the same number. So both will have the same number 3. So prevascular, retrotracheal, both will have the same number 3. So either prevascular or retrotracheal or both can be present. So prevascular generally in front of the trachea. So retrotracheal generally behind the trachea. So then we have lower paratracheal. So this is 4, lower paratracheal. So this is the rough location for you to understand. And aortic, we have subaortic, para-aortic. Then below the carina, subcarinal, paraesophageal, and also pulmonary ligament. Now coming to most important, intrapulmonary lymph nodes. So up to now we have discussed the lymph nodes above the clavicle within the mediastinum. So we haven't discussed the lymph nodes within the substance of the lung. So this is the intrapulmonary hilar lymph nodes. So hilar and intrapulmonary lymph nodes. So these are called as N1 nodes. So very, very important. N1 nodes. So this is a station. So there are 3 stations, N1 station, N2 station, N3 station. So that I will show you in a while. So these hilar and intrapulmonary nodes, so starting from number 10 to 14, these are also called as N1 nodes. So where are they seen? So hilar lymph nodes. So you see somewhere here. So hilar lymph nodes. So hilar lymph nodes, somewhere here we see hilar lymph nodes, and interlobar lymph nodes. So interlobar lymph nodes somewhere here. So between the lobes, and still going into deep. So within the lobe we have lobar lymph nodes, and still going deep within the segments we have segmental lymph nodes, and still deeper in the subsegmental level we have subsegmental lymph nodes. So generally on a CT scan up to lobar, interlobar, you can see segmental and subsegmental bit difficult. So these are the important groups of lymph nodes: supraclavicular, superior mediastinal, aortic, inferior mediastinal, hilar, and intrapulmonary nodes. So no need to know much about this. So, but whenever they ask you what are N1 nodes, you must be knowing this. So it consists of hilar. See, according to the anatomy only. So hilum, at the hilum, the lung is large. So from the hilum, when it goes into lobes, so gradually the substance of the lung is getting divided. So interlobar, lobar. And how is a lobe divided? Segment. So segmental. How is a segment divided? Subsegmental. So this is also called as N1 station. So N1 station, involvement of any one of this. So hilar or interlobar, lobar, segmental or subsegmental. Now based on this, how is the nodal staging given? So N1 means involvement of ipsilateral hilar or intrapulmonary node. So I'll give you an example. Suppose there is a tumor like this. So this is the primary tumor. So this is the primary tumor. And this tumor is causing enlargement of these nodes. Involvement of these nodes. So on a CT, you can see it as enlargement. But if you take a biopsy, you can see malignant infiltration. So if it is causing involvement of any of these nodes, so hilar, interlobar, lobar, segmental or subsegmental, so that involvement is called as N1. So just like T1, T2, T3, T4. So T4 means more dangerous. T1 means less dangerous. In the same way, N1 is less dangerous, less involvement. Now coming to N2. N2 means ipsilateral, mediastinal or subcarinal. So if it is up to this level, so tumor is there and up to this level of lymph nodes are involved, it is N1. Now N2 means, suppose the tumor, so this is the tumor, so this is the tumor, so this is the tumor, so it has involved ipsilateral mediastinal. So it has involved ipsilateral mediastinal. So same side mediastinal lymph nodes have been involved and also the subcarinal lymph nodes. So subcarinal ipsilateral mediastinal lymph nodes. So if this area is getting involved, so it might be involving, so the same side paratracheal, prevascular or retrotracheal, lower paratracheal, subaortic, para-aortic, subcarinal, paraesophageal, pulmonary ligament. So same side. So this is on the right side and the right side nodes are involved within the mediastinum and also the subcarinal area, paraesophageal, pulmonary ligament. All this. So right from below the clavicle up to the pulmonary ligament. You can see I have drawn here below the clavicle up to the pulmonary ligament. So on that side only, disease is on the right and only right side nodes are involved. It accounts to N2. Now coming to N3. Now there is a tumor here. So there is a tumor here. Either there is involvement of ipsilateral supraclavicular lymph nodes. So ipsilateral, so same side. So it has crossed the clavicle and has involved the nodes. So N3 includes ipsilateral, supraclavicular, and also here. So near the trachea, you have another group which also is seen above the clavicle, that is called as scalene lymph node. So ipsilateral, scalene or supraclavicular involvement. Along with that, now this tumor has extended to the other side. So contralateral, mediastinal lymph nodes, either paratracheal, pretracheal, lower paratracheal, or involvement of contralateral, subcarinal, contralateral, paraesophageal, contralateral, pulmonary ligament. So now the tumor is involving same side. So same side, supraclavicular or contralateral, any lymph node. So contralateral, any lymph node. So right from the lowest subsegmental to the highest supraclavicular. So this accounts to N3. So now we have seen if it is within the pulmonary involvement, so this everything corresponds to, N1. So this everything corresponds to N1. So if it is, so this everything is N1, N1, N1. So if the tumor is involving ipsilateral, so ipsilateral like this. So ipsilateral, mediastinal, subcarinal. So ipsilateral, mediastinal, subcarinal. Ipsilateral, mediastinal, subcarinal. So on the same side. So tumor is on the right, and right side mediastinal and subcarinal lymph nodes are involved. So because subcarinal lymph nodes are very well identified on a CT scan, that's why I'm telling it as separately. So this is called as N2. This everything is N2. So whereas N3. So whereas N3. So this is N3. So you can see same side. So same side, scalene or supraclavicular. Along with that, opposite side, any lymph node can be involved. So opposite side, any lymph node can be involved. So that is N3. So this phenomena is N3. So this phenomena is N3. So for your exam, you should know only this. So no need to remember all the categories of lymph nodes. So just know what is N1. So N1 means involvement of lymph nodes in the substance of the lung. So hilar intrapulmonary lymph nodes. So if tumor is here and only this part is involved. So here tumor is here somewhere and this lymph nodes are involved. This is N1. And tumor is here and the same side, mediastinal subcarinal lymph nodes are involved. It is N2. Now tumor is here. Any supraclavicular lymph node is present. It is N3. Or on the opposite side, right from supraclavicular to the lowest part, that is subsegmental, any lymph node is involved, it accounts to N3. It accounts to N3. So generally N3 indicates the tumor has disseminated significantly. So N1, lymph nodes within the substance of the lung. N2, ipsilateral, mediastinal or subcarinal. N3, ipsilateral, supraclavicular or scalene. Along with that, contralateral, any lymph node right from number 1 to number 14. Then coming to, so M stands for metastasis, whereas M0, no distant metastasis. So no any distant metastasis. M1 means presence of metastasis. So M1 indicates there is some metastasis. So this can be further classified into M1A, M1B and M1C. M1A, M1B and M1C. M1A is patient is having either malignant pleural or pericardial. So malignant pleural or pericardial effusions or nodules. So patient is having collection of fluid in the pleura or pericardium and you have noticed it is filled with malignant cells. Or there can be nodules on the pleural surface or pericardial surface which were positive for malignancy on biopsy. So either pleural effusion or pericardial effusion or nodules on the pleural or pericardial areas which are suggested to be malignant. Along with that, for M1A, so patient might be having separate or satellite tumor nodules on contralateral lung. So for example, let this be the primary tumor. On the left side there was a tumor. So on the right side, there are some satellite nodules. So previously in T3 and T4, we have discussed presence of the satellite nodules within the same lobe or in the other lobe in the same lung. Now here tumor is on one side and satellite small nodules are on the other side. So right tumor with left nodules or left tumor with right nodules. Whereas M1B indicates single. So in one organ, either brain, liver, adrenal or bone, single extrathoracic metastasis. Single extrathoracic metastasis. M1C indicates multiple. You can see multiple mets at multiple sites. So simultaneously patient might be having metastasis, brain, bone, liver, adrenal, all this. So why this is important? Because presence of presence of any metastasis will make the disease generally inoperable extensive stage 4. If metastasis is present, irrespective of tumor, irrespective of nodal status, it should be considered as stage 4 disease. And generally, for stage 4, we have stage 4A and stage 4B. So 4A is up to M1A, M1B. If it is M1C, if metastasis is extensive, it should be called as stage 4B. So in stage 4B, generally metastasis will be extensive. But for your level, just know stage 4 disease means presence of metastasis. Anything, either M1A, M1B or M1C. Even a single metastatic feature is sufficient to be called as stage 4. Stage 4. Now let us see the staging in detail. We have stage 0. So stage 0. So this is in accordance to tumor, node and M. So stage 0 means, so there is no nodal involvement, there is no metastasis. See, up to stage 4, there will be M0 only. Only in stage 4, there is presence of metastasis. So here T is tumor in situ, either adenocarcinoma in situ or squamous cell carcinoma in situ. No nodal status, no metastatic lesions, it is stage 0. Then stage 1, we have stage 1A and stage 1B. So this is stage 1. So in stage 1, any T1, so any T1, stage 1A, any T1, N0, M0. So let a M0 or N0. So it can be T1A, T1B, anything. No node status. So no need to worry about this metastasis up to stage 4. So that is an easy clue. Stage 1B, there will be T2A. So it has gone into T2. The tumor size has increased and now it is T2A N0. So this is stage 1. In stage 2, there is 2A, 2B. Stage 2, 2A, 2B. So to call it as stage 2A, so now the tumor has become T2B. So T2B, no nodes. So no need to worry about this metastasis. So no nodes. So up to stage 2A, generally there will be no nodal involvement. Now from stage 2B onwards, so there will be N1. So if N1 is involved, so N1 means, what did I tell you? It is the intrapulmonary hilar lymph nodes. So N1 involvement is stage 2B. So it can be either T1 or T2. Any T1 or T2 with N1 involvement, it is called as stage 2B. Then coming to another stage 2B, now it is T3. Now the tumor is large. Irrespective of nodes, it can be called stage 2B. So what you should understand in stage 2B, if N1 is present with T1 and T2, a small tumor but lymph node involvement, a small tumor but lymph node involvement, so it can be considered as 2B, or A big tumor with no lymph node involvement. So tumor might be big, but still not disseminated into lymphatics. So it can also be considered as 2B. Then coming to stage 3. Stage 3. So this is very, very tricky. Stage 3 is very, very tricky. Now, tumor is small. Tumor is small. So tumor is small, T1, T2. But it has extensive lymph node involvement up to N2. So not only the lymph nodes in the substance of the lung have been involved, even the what you call the mediastinal lymph nodes, such as the paratracheal, pretracheal, they have been involved. So T1, T2 with N2 or T3. Now the tumor is big, T3, and even N1 has been involved. So T3, N1. T3, N1 will also come under stage 3A. Now tumor is very big, T4. So if T4 is present, irrespective, even if nodes are not there also, we call it as stage 3A, stage 3A. So T4 N0 or N1, T4 N0 or N1 is considered as stage 3A. Then stage 3B, now the nodal involvement has become very, very extensive. So the tumor might be small, T1, T2, but you are seeing nodes on the opposite side, or you are seeing nodes on the supraclavicular area. This is called as stage 3B, stage 3B. Tumor T3, T4, T3, T4 with N2 involvement. Now tumor is large, and also N2 is involved. N2 is involved. Same side, mediastinal lymph nodes are involved. So that is also stage 3B. Whereas stage 3C, very big tumor, opposite side lymph nodes are involved. Very big tumor, opposite side lymph nodes are involved. So stage 3C, if there is N3, and also T3, T4, N3, T3, T4, it is called as stage 3C. So for us, very, very important is up to 3A. So up to 3A. So this is not that much extensive tumor. So this can be resectable. So you can resect the tumor. You can still make a surgery. You can still try to make a surgery and remove the tumor, because up to stage 3A, so it might be T1, T2, T3, T4, and even the nodal involvement is on the same side. So you can attempt by removing the whole lung. Up to that, you can do surgery. So from stage 3B onwards, it is very difficult to do surgery because there can be extensive involvement. So from stage 3B onwards, it is unresectable. It is generally unresectable. Now stage 4. So if there is metastasis, irrespective of any tumor, it is called as stage 4. So this TNM staging is bit tricky, but what you need to understand is, so small tumors, less lymph node involvement, will be given less stage of involvement. So large tumors, more extensive lymph node involvement, will be given more stage of involvement, and the higher the stage, the difficult will be to do the surgery. So this completes the TNM staging, and for your exam they will ask you the T important. What is T1? What is T2? What is T3? What is T4? And they can also ask you what is N1, N2, N3, and they may ask you up to stage 2. So more than that, it is even for a postgraduate, it is very difficult to stage. So there is a saying that treating and remembering the treatment of lung carcinoma is very much easier than staging the disease. So it is very difficult to stage the lung cancer because there are so many nodal stations, 3 nodal stations, 14 areas you have to see lymph nodes, and you have to see the size of the tumor. You should screen for metastasis. So it is a hectic task. So for your exam, most probably they'll be asking you what is T1, T2, T3, T4 that we have discussed in detail. What are N1, N2, N3 nodes? And they might be asking you the classification up to stage 2. So in stage 1, we have 1A, 1B. Any T1, N0, M0 is stage 1A, 1B is T2A, N0, M0. So once the nodal involvement starts, it becomes a stage 2. So in stage 2, T2B N0 M0 is stage 2A. In 2B T1 T2 N1. So N1 involvement starts in stage 2B, and T3 N0 M0 is also stage 2B. So N2 involvement starts in stage 3. So what you need to know is N1 involvement starts in stage 2. N2 involvement and N3 involvement starts in stage 3, whereas metastasis happens in stage 4. So once again, you know this basic. So lymph node involvement generally not seen in stage 1. N1 N1 involvement seen in stage 2. N2 involvement and N3 involvement happens in stage 3. Metastasis will happen in stage 4. Let us discuss extra edge in acid-base balance. So first topic, validity of ABG report. Is there a lab error? Is there a mission error that you should know? Sometimes you can find ABGs like this, which are inconsistent and even clinically correlated, where correlation may not be seen. If you see this ABG, pH has reduced, there is some acidosis, PaCO2 has decreased, and bicarbonate has increased. See, whenever there is some acidosis, either CO2 should be increasing or bicarbonate should be decreasing. Now, if you see this pH, so it is looking inconsistent. So most probably there must be an error in the mission. Now, how to identify that there is an error? So you know the basic Henderson-Hasselbalch equation that we have discussed. pH is proportional to bicarbonate by PaCO2. So pH is proportional to bicarbonate and PaCO2 by PaCO2. So pH is nothing but negative logarithm of H plus. So if we take in terms of H plus, so pH is negative logarithm. So the symbols will change now. So proportional to PaCO2 by bicarbonate. Now removing the proportional value and introducing a constant 24. So this will be the formula to calculate H plus value. Now whenever they say pH is nothing but it tells you the amount of H plus in the body. So H plus manually can be calculated with this formula. So there is a important table which will denote for this much amount of H plus, this might be the pH in the body. So what you should know is, you should compare the H plus and given pH, and if they are not correlating, most probably it is a lab error. So this is the detailed table. I'll tell you how to use this. Now for example, I have calculated by the given equation H plus. Now suppose patient H plus is 50. So pH should be somewhere nearing to 7.30. Now suppose his H plus was 75. If H plus was 75, so his pH should be somewhere between 7.10 to 7.15. Now suppose his H plus was somewhere about 30. So his pH should be somewhere between 7.50 to 7.55. So this is how I should use this table. Now after doing in this table, if pH and the H plus are inconsistent, the ABG is probably not valid. If pH and H plus are inconsistent, the ABG is not valid. So for example, suppose I have calculated the H plus. So I got it somewhere around 60. I got it somewhere around 60. So pH should be this value 7.20 to 7.25. But in the question they have given pH as 7.45. So this is inconsistent. So mostly it is a lab error. But it is very difficult and tedious to remember this complete table. So for that I have an easy method which will be helpful to apply in your exam if at all they ask you this question. So what is that? So let us take pH and correlating H plus. So we know that normal pH, if we take 7.35 to 7.45, so the reference value can be taken as 40, 7.40, 7.40. So pH normal is 7.40. So here you have 40. So at 7.40 pH, H plus will be approximately equal to 40. Now, what will happen if the pH decrease 7.30, 7.20? So as the pH decreases, so generally what should happen? H plus ion should increase in the body. So now pH is decreasing from 7.40 to 7.30. So from 40 plus 10, it can increase to 50. So as pH decreases, pH is decreasing by zero point 0.1. What is happening to H plus? H plus is increasing by 10. Now pH, if it has decreased 7.30 to 7.20, approximately H plus in the body will be 60. Now if you go to this side, 7.50, 7.60. So if pH has increased from 7.40 to 7.50, what should happen to H plus? So whenever H plus increases, it is acidosis. Now H plus decreases, it should be alkalosis. So pH is increasing. So what should happen to H plus? It should decrease because increase in pH is alkalosis. So from 40 it can decrease to 10. From 40 it can decrease by 10 and it can become 30. So at 7.50, approximate value of H plus in the body will be 30. Now at 7.60, see, this relation is not that linear when you go into the alkaline range. So here it may decrease to 25. So this is an easy way to remember. So 7.40 pH, 40 will be the H plus, 7.30, 50, 7.20, 60. So as the pH is decreasing by 0.1, H plus tends to increase by 10. In the same way as pH is increasing by 0.1, H plus can also decrease here by 10 from 40 to 30, and at 7.60 it might decrease by 5. So mostly majority of the pH will be in this range. So 7.2 to 7.6. So if you can remember these values, it will be handy. Now let us apply in the given question. So they have given pH 7.30, PCO2 30 and bicarbonate, PCO2 38 and bicarbonate 30. Now let us see whether this is consistent pH or inconsistent or lab error. So H plus, how do I calculate? 24 into PaCO2, 30 by 38. PaCO2 is 38. HCO3 is 30. So it will be 24. So 1.25, it will be roughly 1.25. 24 into 1.25. So H plus should be 30. So when we calculate manually the H plus for the given CO2 and bicarbonate, the H plus value should be 30. So if H plus is 30, what should be the approximate pH? 7.50. But here pH is 7.30. So expected pH is 7.50. But given pH in the question is 7.30. It means most probably it is a lab error. So what you should know is whenever you are calculating the H plus, it should correlate with the given pH. Now suppose if you got H plus as 60, it should correlate with the pH of 7.20. So at least near. So if 7.20 means at least 7.18 to 7.22. So within plus or minus 0.002, you can see the difference. So that range is accepted. So no need to precise that 60 means 7.20. So it can vary slightly, but not this much significantly. So for the given parameters, H plus was 30 in the question. H plus is 30. So the pH should be 7.50. But in the given question, it is 7.30. So it is not correlating. So this is how you should check the validity of ABG report. So instead of following this TDS table, you can just know this simple concept. At 7.40 of pH, H plus concentration will be 40. 7.30 it will be 50, 7.20 60, 7.50 30, 7.60 25. This is a very easy and handy method to check the validity of ABG report. Now we have already studied the causes of high anion gap acidosis and normal anion gap acidosis. So here we are going to study what are the conditions in the body that can cause low anion gap. So again, a brief introduction of anion gap. We know in our body there is a positive and negative compartment. So there is measured positive predominantly made up of sodium and measured negative predominantly made up of chloride bicarbonate. So in between these two, always there is a significant gap in the blood which is called as anion gap. So when will anion gap will decrease? So if you write in simple words the important formula, and we know that there is a measured compartment and unmeasured compartment. So this is measured compartment. So here we have unmeasured compartment. So unmeasured positive ions, they are called as cations. And this everything contribute to unmeasured negative ions called as anions. So to maintain electroneutrality, always total number of positives will try to be equivalent to total number of negatives. So following simple mathematics, unmeasured cations plus sodium. So it means I have included this whole compartment. Unmeasured and measured is generally sodium we take, will be equal to the same thing. Unmeasured anions plus chloride plus bicarbonate. So let me write this together. Okay. So whatever I put in brackets for ease of understanding, those are measured parts. So which I did not include in brackets, those will be unmeasured parts. Now again, following rules of mathematics, so I am going to bring this chloride bicarbonate to this side, and I am going to send this unmeasured cations to other side. So whenever you are trying to bring a positive to the other side, it will become negative like this. So this is simple mathematics. So Na minus chloride plus bicarbonate will be equivalent to, so the same equation can be written like this: unmeasured anions minus unmeasured cations. Simple mathematics. Okay. So what is this sodium minus chloride plus bicarbonate? What is this also called as this parameter? You know, what is this called as? This is called as anion gap. So anion gap will be equivalent to unmeasured anions. So unmeasured anions minus unmeasured cations. Unmeasured anions minus unmeasured cations. Unmeasured cations. So very important relation. So simple mathematics, I have derived that anion gap is equal to unmeasured anions minus unmeasured cations. So here we are discussing what are the causes of low anion gap. So we have understood anion gap is equal to unmeasured anions minus unmeasured cations. So we need, when will anion gap decrease? Low anion gap. So when can this happen? Either unmeasured anions are decreasing, or unmeasured cations are increasing. So any of this. So very simple. So if unmeasured anions decrease, anion gap decreases. If unmeasured cations increase, anion gap will again decrease. So let us see one by one. So let us start with what are the causes of increase in unmeasured cations. So there can be increase in abnormal cations such as lithium. So whenever there is lithium toxicity, or because of some plasma cell disorders, there will be positive immunoglobulins circulating. So cationic immunoglobulins. So one important reason is for unmeasured cations increase, there can be increase in lithium in the body. There can be increased positive immunoglobulins. So there can be increased positive immunoglobulins. Now, what is the reason for decrease in unmeasured anions? So, most important unmeasured anion is albumin. So, decrease in albumin. So, you know that albumin has a negative charge. So, when will albumin decrease in the body? Whenever there is decrease in protein synthesis, as in liver disease, decrease in protein absorption, malabsorption, increase in protein excretion in urine, nephrotic syndrome. So causes for decrease in unmeasured anions. So what can happen? Decrease in albumin. So decrease in albumin. So decrease in albumin. What are the causes of decrease in albumin? Either liver disease, nephrotic syndrome, or malabsorption. And next important cause for low anion gap is some issue in the laboratory whenever there is hyperviscosity of the blood and also severe hyperlipidemia. So whenever the blood is very viscous, hyperviscosity, so the sensors cannot detect sodium and chloride properly. See, for a sensor to detect the sodium and chloride, the blood should be normally viscous in its normal state. So whenever blood becomes very viscous, it will be very difficult for the sensor to identify sodium and chloride. So in this, the value of sodium will be very less estimated when compared to chloride. So if normal sodium in that person's body is somewhere 140, so because of this hyperviscosity and increased lipids in that blood, so that sensor cannot detect sodium properly. So it might only detect 130 or 120. So once the sodium value is falsely reduced, so what will happen if sodium value is reducing? Ultimately, anion gap will decrease. So there are three important reasons: either increased unmeasured cations, decreased unmeasured anions, or hyperviscosity or severe hyperlipidemia. In these conditions, what will happen is the sensors cannot detect sodium properly. They will underestimate the value of sodium. See, they will also underestimate value of chloride, but when compared to chloride, sodium value is very much underestimated. So this was an observation. So the sodium value is decreasing. So what will happen? The anion gap will also decrease. So next concept is, now you have understood a person with hypoalbuminemia, especially such as in liver disease and kidney disease, which are very clinically relevant to my day-to-day practice. See, I may not see lithium toxicity. I may not see plasma cell disorders. I may not see this hyperviscosity and severe hyperlipidemia on day-to-day basis, but I will definitely see a kidney disease. I will definitely see a malabsorption. I will definitely see a nephrotic syndrome in my practice. So in those conditions, there is a concept called as corrected anion gap. So corrected anion gap in hypoalbuminemia. So whenever there is less albumin, what is going to happen? The anion gap generally in these patients will be low, but I have to standardize the anion gap equivalent to a normal person of that given age. We already have discussed that in patients with hypoalbuminemia, the normal anion gap is lower than 12 milli equivalents per liter. In a normal healthy person, adult, the anion gap is in the range of 8 to 12 milli equivalents. So in a patient with hypoalbuminemia, generally the anion gap will be lower than 12 milli equivalents. But my goal is whenever I see a patient with hypoalbuminemia, I should try to standardize his anion gap with respect to a normal healthy individual. So by comparing that, I can know whether there is any high anion gap in this patient. For that, there is a relation. For every 1 gram per deciliter decrease in plasma albumin. So if at all a patient's albumin has decreased by 1 gram per deciliter. So normal plasma albumin is 4.5 gram per deciliter. So for every 1 gram per deciliter decrease in albumin, the anion gap can decline by 2.5 milli equivalent. So this is a very significant value. So if normal albumin is 4.5, okay, 4.5 gram. Now the albumin has decreased by 1 gram. So if albumin has decreased by 1 gram, so the anion gap can also decrease by 2.5 milli equivalents per liter. So this is one relation that you should know. So it was an observation. So if albumin decreases by 1 gram, the anion gap decreases by 2.5. So anion gap decreases by 2.5 milli equivalents. Now let us see how is this relation clinically relevant and how can a question be asked. So there was a patient, for example, with some liver disease or nephrotic syndrome. His serum albumin was 2.5 gram per deciliter. And when I calculated his anion gap, it was 12. It was 12. So they'll ask you, what is the corrected anion gap in this patient? When they ask you corrected anion gap, you have to standardize this to a normal person whose albumin is 4.5 gram per deciliter. Suppose this patient's albumin is 4.45 gram per deciliter, what will be his anion gap? So you should standardize this anion gap to with respect to normal serum albumin. So what has happened to the serum albumin? It is 2.5 grams. So serum albumin in the question is 2.5 gram. So what is normal serum albumin? 4.5 gram. So the difference here is plus 2. So we have understood that for every 1 gram decrease in plasma albumin from normal value, anion gap can decline by 2.5 milli equivalent. So for 1 gram decline, it will be 2.5 milli equivalent decline. So if at all albumin is increased by 1 gram, the increase in anion gap will be 2.5 milli equivalent. So the relationship can be vice versa. So here to standardize it to normal individuals albumin. So normal individuals albumin, we can take it as 4.5 gram. So to standardize that, if we standardize this albumin to normal individual albumin, so anion gap can increase by 5 milli equivalent. So for 1 gram, it will be 2.5. For 2 gram, it will be 2.5 into 2, that is 5 milli equivalents. So if they ask you what is corrected anion gap in this patient, so it will be the reported anion gap, so that you get in the patient report. Along with that, we have to add 5 milli equivalents. So the corrected anion gap in this patient will be 12 plus 5, 17. It means it is a high anion gap. So probability of this patient having high anion gap metabolic acidosis. So in simple terms, this corrected anion gap is nothing but we are standardizing the anion gap with respect to normal albumin. So if the albumin is 2.5 gram per deciliter, the reported anion gap is 12. But I want to know if his albumin was normal actually. What might have been the anion gap? So what might have been the anion gap if his albumin was normal? It would have been 17 milli equivalents, which generally indicates high anion gap. So this corrected anion gap will help me to identify any causes of high anion gap metabolic acidosis in this given patient. So if at all I am not seeing corrected anion gap, what will happen? So I think that this fellow is having anion gap of 12. So he is having a normal anion gap. But if I standardize it to 2 normal albumin level 4.5 gram per deciliter, now I came to know that his anion gap actually, if albumin was normal, was will be 17 milli equivalent, which is high. So I can think that this patient might be having some high anion gap condition. So most probably it might be an high anion gap metabolic acidosis. Then what is the concept of base excess and base deficit? Let us see the definitions. Under standard condition, so normal room temperature and normal parameters. So under standard conditions, positive base excess means metabolic alkalosis. So it means positive base excess, the amount of acid that returns the pH of blood sample to normal. So base is in excess. So whenever base is in excess, it means there is some alkalosis. So positive base excess means the amount of acid that returns the pH of blood sample to normal value. Negative base excess means, so there is no base excess. So base excess negative means there might be less base. So this phenomena is also called as base deficit. So for your exam, base deficit is important. So base excess means there is excess base. So it is a metabolic alkalosis. So whenever there is excess base, you should add some acid so that pH will come back to normal. When there is base deficit, there is less base. So less base means metabolic acidosis. So here, to make it to normal, an alkali should be added. So the amount of alkali that should be added to return the pH of a blood sample to normal is nothing but base deficit. What clinically relevant is always base deficit in your practice. So generally for most of the metabolic alkalosis, if you treat the underlying condition or if you give saline, so no need to add any acid to bring back the pH to normal. But whereas in metabolic acidosis, in few conditions, even if you treat the underlying condition also, the pH may not come back to normal. In such cases, addition of base might be required. So this phenomena is base deficit. So base deficit is nothing but the amount of base that should be added to return back the pH of blood sample to normal. Now let us see one question. So there was a 50 kg female with severe metabolic acidosis. So generally severe metabolic acidosis means refractory metabolic acidosis. pH is less than 7.10 or less than 7. So the range is 7 to 7.10. So even you are treating the underlying condition, but it is not improving. And patient had parameters pH 7.05. So it is less than 7.10. PCO2 12 and oxygen 108 and bicarbonate of 4. So bicarbonate is 4, very less, and pH is also very less. At this low pH, body's metabolism will not happen properly and the patient can develop some end organ damage. Now what should be the approximate quantity of sodium bicarbonate that she should receive in first 4 hours? So for this we should calculate base deficit. Now they're asking you how much amount of base should be added in the first 4 hours so that you can improve the pH. So we have a formula for base deficit. Base deficit is equal to 0.5 into body weight. So this is from the recent CMDT 2019, 0.5 for females and 0.6 generally for males. But usually for ease of calculation, we take a standard value of 0.5 for both. But if they ask you precisely, 0.5 is the total body water in females and 0.6 is total body water in males. So for males, usually we take 0.6, for female 0.5. But if they ask you in emergency, if you want to calculate, you can use this value 0.5 for both, no issue. So 0.5 into body weight. So how much is the body weight? 50 into 24 minus 4. So 4 is the bicarbonate here. So 0.5 into 50, it will be about 25. So 25 into 20. So it will be 500. So it will be about 500 milli equivalents. So it will be about 500 milli. This is the base deficit. So if you give him some amount for 500 mg milli equivalents, so most probably the patient's pH can brought to be normal. But they are asking you how much should be given in first 4 hours. So when you find base deficit of 500 milli equivalents, no need to dump 500 milli equivalents immediately in the patient. So that will be counterproductive. So that much amount of sodium bicarbonate, so patient cannot tolerate. So it is given in a sequential manner so that you should understand. So let us see what is the sequential manner, how bicarbonate is generally administered. So half of the calculated deficit should be administered within first 3 to 4 hours. See, ultimately, to correct a metabolic acidosis, it is not the addition of bicarbonate that is important. It is treating the underlying disease. So now the pH has become dangerously low. You should give some bicarbonate. So you have calculated the base deficit in the first 3 to 4 hours. So in the first 3 to 4 hours, half can be given. So half can be given and you can treat the underlying disease simultaneously. You repeat the ABG. So if the ABG is improving, patient is clinically stable, no need to give. So if still ABG is not improving, you can give the rest of half in that whole day slowly. So in the initial first 3 to 4 hours, we give half. So later part of the day, we can give half if the patient is not improving with the other supportive management for the disease. Now, if they ask you in emergency situation, how much maximum you can give during the first hour? So in general, in severe acidosis, 50 to 100 milli equivalents can be given during first hour of therapy. So first hour of therapy. So this is very, very important that you should know in the question. So if in the question, if they ask you, what is the patient's base deficit? What is the patient's base deficit? Answer will be 500 milli equivalents. If they ask you how much can be given during the first 4 hours, so it should be half of this. So 500 by 2 in the first 4 hours. So in the first 4 hours, I'll just mark it red for first 4 hours for 500 by 2. So it should be approximately 250 milli equivalent. So best answer is option A. Option A. But if they ask you how much can be given during the first hour, so first hour the range is 50 to 100 milli equivalent. So three important questions. If they just mention how much is the base deficit, your answer should be 500 milli equivalents. How much can be given during first 4 hours? Answer should be 250 or 240, half of this. How much can be given during the first hour of therapy? So irrespective of base deficit, when there is a severe metabolic acidosis, you can give a trial of 50 to 100 milli equivalents during the first hour of therapy. Next topic is urinary anion gap. So we have discussed about anion gap in blood. This is urine anion gap, also written as UAG. So why was urinary anion gap actually designed? Urinary anion gap was designed to differentiate a normal anion gap metabolic acidosis of a renal cause versus GIT cause. So can differentiate urinary anion gap, this parameter. This is an old parameter not used nowadays. So it can be differentiate, it can differentiate normal anion gap metabolic acidosis, normal anion gap metabolic acidosis of GIT cause. So GIT cause commonly encountered is diarrhea versus a renal cause. commonly encountered is renal tubular acidosis. So generally, urinary anion gap can differentiate normal anion gap metabolic acidosis of GIT cause such as diarrhea versus renal cause, that is renal tubular acidosis. So not routinely used in our clinical practice as of now in the emergency situation, but still questions were asked previously. So again in the urine, there can be two compartments, a positive compartment, a negative compartment. So in the positive compartment, the measured compartment is predominantly made up of sodium, potassium, whereas the negative compartment is made up of chloride. And always between measured positives and measured negatives, a very slight gap called as urinary anion gap can exist. So the formula in the urine is different. Urinary anion gap is the difference between measured positives minus measured negatives within the urine. Measured positives minus measured negatives. And if you calculate with this formula, the value of urinary anion gap will be roughly 0.50 to 5 milli equivalents. So 0 to 5 milli equivalents. But majority of labs take 0 as standard value. So whenever you take 0 as standard value, 0 to 5 milli equivalents. So majority of labs can take 0 as standard value. So if at all a urine anion gap is increasing, so it is increasing more than 0. So the value can be called as urinary anion gap as positive. So they mention it as positive. Now if urine anion gap is decreasing, so anything decreasing less than 0 is a negative value. So increase in urine anion gap is called as urine anion gap positive. Decrease in urine anion gap, it is called as urine anion gap negative. Very important is in the unmeasured positive, there is an ion called as NH4 plus. So NH4 plus contributes to the unmeasured compartment. NH4 plus contributes to the unmeasured compartment. Let us see how this urinary NH4 is clinically relevant. So this urinary NH4. So this urinary NH4 is clinically relevant. So how is it actually produced? So write down excess H plus in urine binds with NH3 and excreted as urinary NH4 plus. So this is the basic concept that you should know. So whenever there is excess H plus in the urine, it binds with NH3 and ultimately within the urine it is excreted as urinary NH4 plus. Now let us see few conditions. So before that, a simple logic, urinary NH4 plus can therefore signify H plus excretion. It means that whenever urinary NH4 plus is seen more, it means more amount of H plus has come into the urine and bound with NH3 plus. It means H plus has been excreted very well. Now if urinary NH4 is less, it means H plus and NH3 are not binding. So it means the amount of H plus excreted into the urine was less. So by seeing the urinary NH4 plus, so one can signify or one can know the amount of H plus excretion. If H plus was excreted more into the urine, what will happen to urinary NH4 plus? It will increase. If H plus is not properly excreted into the urine, urinary NH4 plus will be less. Urinary NH4 plus will be less. Let us see rule number 1. Now because of any disease, if urinary NH4 plus increases. Now because of any disease, if urinary NH4 plus increases. So automatically what happens to Na plus K plus value? It will decrease. So whenever Na plus K plus value decrease, urinary anion gap will decrease. So what is decrease in urinary anion gap, also written as urinary anion gap negative. Now try to understand this phenomena. Now this is a compartment like this. So this is a positive compartment. You have measured part and unmeasured part. So generally, if you take a bottle for example, this is the positive compartment, measured part, unmeasured part. So just like in this bottle, always this measured and unmeasured will mutually adjust to maintain the total volume of the bottle. Now because of some disease, if measured is decreasing, unmeasured gradually will increase. So if unmeasured is increasing, measured will decrease. So it is just like always the measured and unmeasured compartments will mutually adjust to maintain the total volume of given compartment. Now in the question, NH4 plus is increasing. So here I told you increase in urinary, whenever urinary NH4 increases, automatically Na plus K plus will decrease. So whenever Na plus K plus decreases, so if this value decreases, what happens to urinary anion gap? It will decrease. So whenever urinary anion gap decreases, it is called urine anion gap negative. Now coming to the second scenario, if because of some disease, urinary NH4 plus is not at all found, it is significantly decreased. So automatically what will happen to Na plus K plus? It will increase. So whenever Na plus K plus increases, urine anion gap increases. So urine anion gap increases. It is simple mathematics. So what is urine anion gap increase also called as? Anything more than 0 is positive, anything less than 0 is negative. So urine anion gap is positive here. Now let us see how will urine anion gap change with respect to disease. So renal cause. So we go for most common type of RTA, that is type 4 renal tubular acidosis. On other side, GIT cause most important diarrhea. Now what is the issue in type 4 RTA? So in type 4 RTA, there will be decrease in H plus and K plus excretion. So whenever H plus is not going into urine, what will happen to urinary NH4 plus? It will decrease because H plus is not secreted into the urine. H plus is not going into the urine. So it cannot bind with NH3 and urinary NH4 plus cannot be formed. So whenever urinary NH4 plus is decreasing, so these are the sequence of events. So what happens to urine anion gap? It will be positive. Now in GIT cause, there is loss of bicarbonate. There is loss of bicarbonate from GIT. So whenever there is loss of bicarbonate from the GIT, now here the kidney is working well. The problem is within the GIT. So whenever bicarbonate decreases in my body, so H plus will tend to be higher. So whenever there is increased H plus in my body and my kidney is functioning well, so what will my good kidney do? My kidney will try to excrete all the excess H plus. So usually H plus and bicarbonate will be in equilibrium. Now because of a disease, bicarbonate is decreasing because of loss of bicarbonate from GIT. Now if the kidney is functioning well, this kidney will try to excrete all this H plus from the body. See, kidney's function is to excrete something which is excess in the body. So loss of bicarbonate from GIT, because kidney is still functioning well, kidney tries to excrete excess H plus, because all these H plus are going into the urine, there will be increased urinary NH4 plus. So whenever urinary NH4 plus is increased, these are the sequence of events. So what happens to urinary anion gap? It will become negative. So as the name indicates, GIT cause urinary anion gap will be negative. There are only 3 points that you should know here. When is urinary anion gap negative? In the name itself there is GIT. So in GIT cause it is negative. Urinary anion gap positive, generally renal cause. Generally renal cause. And what is important parameter in this urinary anion gap? It is urinary NH4 plus. So this statement is also very, very important. Urinary NH4 plus can signify, urinary NH4 plus can signify H plus excretion. It is negative in GIT cause, positive in renal cause. Next topic is mixed metabolic disorders. So these are some complex disorders where there can be two metabolic disorders. And here important is you should calculate delta anion gap, delta bicarbonate, and you should compare. So actually this is a very, very complicated concept, but let us make it very easy for your exam. So you must be knowing this relation. So in high anion gap metabolic acidosis, so we have discussed this in your class in detail. For every 1 milli equivalent increase in anion gap, for every 1 milli equivalent increase in anion gap, so bicarbonate decreases by 1 milli equivalent. So bicarbonate decreases by 1 milli equivalent. So this is called as the relationship between increase in anion gap and decrease in bicarbonate. So in high anion gap metabolic acidosis, for every 1 milli equivalent increase in anion gap, bicarbonate generally decreases by 10 milli equivalent. So for example, if anion gap is 15, bicarbonate, so bicarbonate, let this be the given set of ABG. So patient's pH 7.33, PaCO2 35, bicarbonate 20, and anion gap is 15. So if you see this, very simple. So pH has decreased, CO2 has decreased, bicarbonate has decreased. Any decrease in pH, it is acidosis. Change in pH with respect to parameter, same direction. So no doubt it is metabolic acidosis. So there is high anion gap. So if you take normal anion gap, 8 to 12 is the range. Reference value is 10. So this is high, 15 is high. So it is an high anion gap metabolic acidosis. So whenever there is a high anion gap metabolic acidosis, as discussed previously in the ABG algorithm, you can see in your notes, you should compare change in anion gap and change in bicarbonate. So let us see change in anion gap first. So how much has the anion gap changed in the question? So change in anion gap is also written as delta anion gap. So how much is normal anion gap? It is 10. So normal value is 10. So how much is given in the question? 15. So here in the given question, anion gap has increased by 5. So it is 5. So change in anion gap is how much? 5. So change anion gap has increased by 5. So change is 5. Then you should compare change in bicarbonate. So change in bicarbonate, also written as delta bicarbonate. So how much is normal bicarbonate reference value? Let us take it as 25. How much is given in the question? 20. So bicarbonate has decreased by 5. So how much is the change? Again it is 5. So here anion gap changed by 5, bicarbonate also changed by 5. So delta anion gap and delta bicarbonate are correlating. So we have already discussed in a pure high anion gap metabolic acidosis. In an isolated high anion gap metabolic acidosis, so for every 1 milli equivalent increase in anion gap, bicarbonate decreases by 1 milli equivalent. So if there is a single disorder, so only a single metabolic disorder, and that too a single high anion gap metabolic acidosis, this relation will be preserved. Now, if at all there is some alteration in this relation, so if delta anion gap is more than delta bicarbonate or delta bicarbonate is more, so if there is some what you call deviation from this relation, there can be existence of a mixed metabolic disorder. Now, for identification of mixed metabolic disorder, again, clinical history is very, very important. So, clinical history is very, very important. So, I hope you have understood the concept. So, if it is an isolated or single metabolic disorder, that too high anion gap metabolic acidosis, so delta anion gap and delta bicarbonate will be correlating. The relationship will be like this. For every 1 milli equivalent increase in anion gap, bicarbonate will decrease by 1 milli equivalent. So if there is some deviation in this relation, there can be a mixed metabolic disorder. Now let us see an example. So previously asked Ames question. So there was a patient with renal failure. And he developed vomiting in ICU. So patient's presentation, renal failure, and also there is vomiting. You performed an ABG. So these are the parameters. Anion gap is given. They're asking you what is the disorder. So whenever you see pH 7.40, PaCO2 40, bicarbonate 25. So if you see only up to here, you feel it is normal parameters. But very, very important in this question, there is a relevant clinical history and also abnormally high anion gap. So whenever there is a high anion gap with relevant clinical history and patient is in ICU, always take it as significant. So let me write down the parameters and explain you better. So pH 7.40, PaCO2 40, bicarbonate 25, and anion gap is 20. So always whenever they give you ABG, you should go with history-based approach first. Next will be ABG based approach. So history based approach. What can this patient probably develop with the given history? So patient is having renal failure. Renal failure generally causes high anion gap metabolic acidosis. So high anion gap metabolic acidosis. And vomiting generally causes metabolic alkalosis. So vomiting generally causes metabolic alkalosis. Now, if you see in this patient, there is something peculiar. There are two metabolic disorders, that too they are mutually opposite. So metabolic acidosis, metabolic alkalosis, they are mutually opposite. So whenever there are two mutually opposite metabolic disorders, what can you expect in the pH? pH must have normalized. So there is an acidosis, there is an alkalosis. Mutually opposite disorders can cancel each other, normalizing the pH. So that's why, because there were mutually opposite disorders, so that might be the reason for normalizing the pH and the parameters. Now coming to ABG wise approach. So ABG wise approach. Now most important here is high anion gap with pre-existing clinical scenario, renal failure and vomiting. So whenever there is high anion gap with relevant history, you should always take it significant. So in this given question, anion gap is high, there is a relevant clinical history. Because of that, chances of high anion gap metabolic acidosis in this patient is there. So there is high anion gap and also relevant clinical history renal failure. So patient might be having a high anion gap metabolic acidosis. So we know that relation in high anion gap metabolic acidosis, for every 1 milli equivalent increase in anion gap, bicarbonate should decrease by 1 milli equivalent. Now let us see whether this relationship is followed here. So what is happening to the anion gap here? So if you take normal value as 10, here in the question it is 20. So anion gap has increased by 10. So following this relation, what exactly should have happened? So bicarbonate. So trend in bicarbonate. So if you take normal value of 25, so normal value is 25. So what should happen to bicarbonate? It should have been decreased by the same amount. So bicarbonate should have been decreased by 10 and it should have stayed at 15. But in the given question, bicarbonate is 25. See, if there was only a single isolated high anion gap metabolic acidosis in this patient's body, bicarbonate should have stayed at 15. But in the question, given bicarbonate is how much? 25. So given bicarbonate is very much higher than expected bicarbonate. So whenever given bicarbonate is higher than expected bicarbonate, so there can be chances of additional metabolic alkalosis. So there is some other disorder which has added up bicarbonate to the patient's body, bringing it to 25. Now, within the given history, is there any disorder capable of adding bicarbonate to the body? Yes, vomiting. So it causes metabolic alkalosis that we know. So here there is a high anion gap metabolic acidosis. How are you telling? There is anion gap high and relevant clinical history. So along with that, what you have identified in the ABG, if it was only high anion gap metabolic acidosis, if there was only high anion gap metabolic acidosis, the bicarbonate should have stayed at 15, but it has again reached to 25. So there is some other disorder, that has increased the bicarbonate. So there is additional metabolic alkalosis. Once again, see the history. Is there any disorder capable of causing metabolic alkalosis? Yes, vomiting. So the best answer is high anion gap metabolic acidosis with additional metabolic alkalosis. So the best answer is option C. The best answer is option C. So whenever there is a high anion gap metabolic acidosis, always see this relation. So is it a single isolated high anion gap metabolic acidosis? Is there any additional metabolic disorder? So in this case, if it was a single high anion gap metabolic acidosis, bicarbonate should have decreased to 15 and it should have stayed there. But in the question, bicarbonate has increased to 25. It means there is some other disorder that has increased the bicarbonate. So any disorder that increases bicarbonate, it is called as additional metabolic alkalosis. So correlate with the clinical history. There is vomiting. It can cause metabolic alkalosis. So the answer is high anion gap metabolic acidosis with additional metabolic alkalosis, option C. Let us see another question. Patient with DKA develops diarrhea in ICU. You performed ABG. These were the parameters. What is the disorder? So whenever they give you any question of ABG, first is history-based approach or history-wise approach. So in the given question, patient is having DKA. So DKA will cause high anion gap metabolic acidosis. Diarrhea can cause normal anion gap metabolic acidosis. So this patient is having two metabolic disorders and these two metabolic disorders are acidosis. So patient is having a high anion gap metabolic acidosis. Along with that, an additional metabolic acidosis in the form of diarrhea, which is generally a normal anion gap metabolic acidosis. Now let us see whether there are two metabolic disorders with the help of ABG wise approach. So pH 7.10, PaCO2 15, bicarbonate 4, anion gap 20. Now solve the pH. It is decreased, CO2 decreased, bicarbonate decreased. Any decrease in pH is acidosis. Change in pH with respect to parameter same direction. So what should be the name? Metabolic acidosis. And anion gap has increased. So this is high anion gap metabolic acidosis. So if you don't know the concept of comparing this change in bicarbonate and change in anion gap, so majority will mark high anion gap metabolic acidosis only. But we know in high anion gap metabolic acidosis, always you should check, is it an isolated solitary high anion gap metabolic acidosis or there is presence of any other additional metabolic disorder. So for that, see the relation. For every 1 milli equivalent increase in anion gap, bicarbonate decreases by 1 milli equivalent. So I have oversimplified that delta anion gap, delta bicarbonate, so that you can use this routinely for solving the questions. So for every 1 milli equivalent increase in anion gap, bicarbonate decreases by 1 milli equivalent. Now let us see, is this relationship followed in this question? So with respect to anion gap, if I consider normal value as 10, so in the question, how much is the value? 20. So it has increased by 10. Now coming, so bicarbonate from normal value of 25, it should have decreased by 10 and it should have stayed at 50. But if you see in the given question, bicarbonate has become 4. So here, given bicarbonate in the question 4 is very much less than expected bicarbonate, that is 15. So if it was a single high anion gap metabolic acidosis, bicarbonate should have been at 15. But there was some other pathology decreasing the bicarbonate to 4. So anything that decreases bicarbonate should be considered as additional metabolic acidosis. Is there any disorder with the clinical history capable of causing additional metabolic acidosis? Yes, diarrhea. So the answer is high anion gap metabolic acidosis, putting this together with additional metabolic acidosis. So this additional metabolic acidosis is due to diarrhea and it is usually normal anion gap metabolic acidosis. So point to understand here is, if it was a single high anion gap metabolic acidosis, if it was only a single high anion gap metabolic acidosis, bicarbonate should have stayed at 15. But in the question, it has decreased to 4. So given bicarbonate is very much less than expected bicarbonate. So there was some other disorder which has decreased the bicarbonate very much. So any disorder that decreases bicarbonate in excess is an additional metabolic acidosis. So the complete answer is high anion gap metabolic acidosis with additional metabolic acidosis. So because two metabolic acidosis were present, the pH has become very, very low. So 7.10. Usually it is a borderline severe metabolic acidosis. You can see bicarbonate has also decreased to very low level, that is 4. So this is how we should solve mixed metabolic disorder. So we have understood the comparison between delta anion gap and delta HCO3. So whenever they are correlating, generally there will be a single high anion gap metabolic acidosis, there will be no mixed metabolic disorder. But whenever they are not correlating, so there can be either an additional metabolic alkalosis or additional metabolic acidosis. Here you can also observe another relationship. So in this question, for example, if you take, so delta anion gap is 10, okay, whereas delta bicarbonate, so how to calculate delta bicarbonate? Normal value of bicarbonate minus given value. So how much is it given? 25. So here bicarbonate, the given value is 25. It has increased to 25. It is 0. So if you observe here, delta anion gap is very much higher than delta bicarbonate. So whenever you see this relation, whenever delta anion gap is more than delta bicarbonate, so there can be coexistence of additional metabolic alkalosis. So this is nothing but whatever we have seen up to now, we have derived an extra relation. So the concept that you have learned up to now is the same. So an extra point that we are seeing here is in the given question, delta anion gap, change in anion gap is very much higher when compared to change in bicarbonate. See, anion gap has what you call has increased, but bicarbonate is not falling down proportionately. So delta anion gap is more than delta bicarbonate. So whenever anion gap increases, but bicarbonate is not proportionately falling down. So whenever anion gap increases, bicarbonate should fall down. But bicarbonate is not falling down. It means there is some other disorder adding bicarbonate to the body. Because of that, bicarbonate is not falling down. So it can be an additional metabolic alkalosis. Whereas in the next question, if you see here, delta anion gap here also. See, now this is the 20 and 10. So the change in anion gap is only 10. The change in anion gap is 10. Delta anion gap here is 10. So whereas delta bicarbonate, so if they ask you to calculate here, so how much is normal bicarbonate? 25. So here it how much is it given bicarbonate? 4. 25 minus 4. So delta bicarbonate is 21. So in the given question, delta anion gap is very much less than delta bicarbonate. So whenever you see such thing in a relation, there is possibility of additional metabolic acidosis. So there is possibility of additional metabolic acidosis. It means that the anion gap has increased. Anion gap has increased. So, but significantly bicarbonate has fallen down. So it has fallen down excessively. So it means the rise in anion, when compared to rise in anion gap, the fall in bicarbonate is more. So bicarbonate has fallen down excessively. So why will bicarbonate decrease excessively when there is some other additional disorder which is bringing the bicarbonate down? So if you find this relationship also, if delta anion gap is very much less than delta bicarbonate in a given question, so there is probability of additional metabolic acidosis. So as I told you earlier, you can use this thing that I have explained here, history wise approach and ABG wise approach, and that is very easy. So this delta anion gap and delta bicarbonate may be a bit confusing, but if you know the concept, so in a isolated high anion gap metabolic acidosis, the delta anion gap and delta bicarbonate will be correlating. If there is an additional metabolic alkalosis, delta anion gap will be very much higher when compared to delta bicarbonate. If there is additional metabolic acidosis, delta anion gap will be very much less than delta bicarbonate. So either you can use this delta anion gap, delta bicarbonate relation, or just in simple words, for every 1 milliequivalent increase in anion gap, bicarbonate should decrease by 1 milliequivalent. So you compare whether the relationship is happening the same. If it is not happening, so if given bicarbonate is higher than expected bicarbonate, it is an additional metabolic alkalosis. If given bicarbonate is very much less than expected bicarbonate, so it can be an additional metabolic acidosis. So this is the most simple method. So instead of writing down those delta anion gap, delta bicarbonate, so you can just use this. For every 1 milli equivalent increase in anion gap, bicarbonate decreases by 1 milli equivalent. You can just calculate the difference. So what has happened to anion gap? What has happened to bicarbonate? You can see the relationship between given and expected. So this is very easy to solve mixed metabolic disorders. So another question, a patient with DKA, excess alcohol consumption. So his pH, PaCO2 and bicarbonate is given. They are asking you the diagnosis. So by history, what can happen in this patient? DKA, there can be an high anion gap metabolic acidosis. So excess alcohol consumption will also cause metabolic acidosis. And always whenever there is excess alcohol consumption, also suspect some respiratory depression. So if there is alcohol intoxication, patient can also have respiratory depression and also he can develop respiratory acidosis. So when a patient with DKA and excess alcohol consumption comes together, you can suspect not only metabolic acidosis. So DKA also later on can cause diabetic ketoacidotic coma where there can be respiratory depression. Even excess alcohol consumption can also cause respiratory depression and respiratory acidosis. Now let us see an ABG and find out what exactly is happening in this patient. pH 7.2, PaCO2 50 and bicarbonate 20. So pH is reduced, PaCO2 is increased, bicarbonate is reduced. So any decrease in pH anywhere is acidosis, Now the question is whether this is a metabolic acidosis or respiratory acidosis. Now if you see this, there is something peculiar. PaCO2 is increasing, bicarbonate is decreasing. So always in a simple acid-base disorder, primary change and compensation will be moving together. So if primary change and compensation are not moving together, either it has to be a mixed acid-base disorder or ABG may not be valid. See, to call it as valid ABG, you know how to calculate it. Even if you calculate this, this becomes a valid ABG. And most importantly is the history here. So history, there is metabolic acidosis in terms of bicarbonate decrease and CO2 is increasing in terms of respiratory acidosis with respect to excess alcohol consumption. So most probably it should be a mixed acid-base disorder. So both respiratory acidosis and metabolic acidosis. So it can be written as metabolic acidosis and respiratory acidosis. So you can write it in any way, either respiratory acidosis and metabolic acidosis or metabolic acidosis and respiratory acidosis. So this is a mixed acid-base disorder. So the concept here is this is an acidosis. Now if you observe here CO2 and bicarbonate, if it is a simple acid-base disorder, always these parameters should be moving together. But whenever they are not moving together, it means it is not a simple acid-base disorder. Probability of mixed acid-base disorder can be there. Now compare the history. Is there probability of two disorders existing here? Definitely yes. The patient is having DKA and excess alcohol consumption. So DKA generally causes metabolic acidosis. Excess alcohol consumption can also cause metabolic acidosis. It can also cause respiratory depression and respiratory acidosis. So this patient can have both. So even the history is telling two disorders and given pH, PaCO2 and bicarbonate is also telling the same. So bicarbonate decrease is metabolic acidosis. CO2 increase is respiratory acidosis. So it is a metabolic acidosis and respiratory acidosis, a mixed acid-base disorder.